The handheld? Ooh. Handheld. Yeah, well, but we do for the recording. And my phone is doing this. Okay, great. Um, Hi, everybody. This is my diva moment. Um, Welcome to the first in our four-part educational series in the Neighborhood Conversations group. We're so excited that you're here, and we're super grateful to you for being here and for all the behind-the-scenes work you've done to support this. My name is Owen. I'm part of the Equity and Inclusion Committee in Bethel and also part of the Neighborhood Conversations group. And we have Lisa and Julie and Jess and Cindy, who are all making the magic happen behind the scenes. So just a little context for today. This group has been thinking about the issue of safety and policing in our community, and we came together in October to host a series of Hamlet-specific conversations. So we did one in Gilead, one in East Bethel on Christian Hill Road. We did one in the Cleveland Brook Road area. We need a catchy name for that neighborhood. We did a downtown one, and we did one on Camp Brook Road as well. And we really asked people a series of questions about what's going on in your community, what are some issues of safety that you're thinking about, how has our new relationship with the Windsor County Sheriff impacted that? Have you seen changes? What's working, what's not working with that contract? And then what are some ideas that you have for how we can address some of the root issues that we're navigating? And from that came a whole bunch of really exciting ideas and a bunch of questions. And so these neighborhood conversation educational series events are attempting to answer some of those questions and continue the dialogue. So today we're going to be talking about substance use disorder, substance abuse prevention. We're super excited that Roz Very is here, who is a family and substance abuse nurse practitioner. Ish, yeah. And a whole bunch of other letters too. You have many credentials. But Roz is over at Gifford and works in multiple locations at Gifford doing work around substance use and prevention and treatment. And so today we're really talking about what's going on, what is substance abuse, what can we do about it as a community, how can we reach out, how can we help people who are both navigating it, and how can we prevent people from becoming addicted in the first place, if that's possible. A couple of housekeeping things. We have bathrooms in the back through those double doors. They're single stall restrooms. There are snackies. Go for the snackies. Feel free to get up and move around. We do have Orca here. Thank you, Orca, who is recording this event so that in the future we can put it on the Bethel Strong website and it will be publicly available for the folks who weren't able to make it here today. And I think that's everything. I'm going to pass it over to you. Thank you so much for being here.
All right. This has some heft to it here. All right. So thank you so much for being here, everyone. I'm really excited to spend a little bit of time on this beautiful afternoon talking with you all about substance use disorders. My name is Roz Very. I'm a nurse practitioner, board certified in family medicine, and then, I am also certified in addiction from the ANCB. I currently run Gifford Healthcare's outpatient addiction medicine clinic. So we're based in Randolph, and then we also spend one day in Berlin. My disclosures are that I'm employed by Gifford. However, they are not paying me to be here. No one is, and I'm expressing my own views tonight. Our objectives are, so we're going to talk about the risk factors for addiction, the protective factors. I want to talk a little bit about kind of the basic changes that are going on in the brain, a healthy brain and the brain of someone struggling with addiction. We're going to talk about how opioid use disorder specifically is diagnosed and what the treatment options are and what you can do to help. And then I will talk a little bit about our clinic, what we offer, and how you can get in touch with us. So I wanted to kind of start today by acknowledging that this can be a really difficult topic for people to talk about for a lot of different reasons. And each one of us here today brings different experiences with addiction. And as a result, we probably see it in pretty different ways as well. Today, I want to give you my perspective as a medical provider, as someone who's working with folks with substance use disorders every day. And I feel like it's important to tell you that even though most people, when I tell them that I work in addiction medicine, I get some kind of response of like, wow, that must be really depressing, or how can you do that all day? And to me, this work actually is not depressing. It's challenging and it can certainly be heartbreaking, but here's why I feel hopeful and inspired to do this work. This is a chronic disease that we actually have really amazing treatment options for. Actually, ones that are more effective than other diseases like high blood pressure or diabetes. So that makes me feel hopeful. And every day I have the opportunity to watch people, to witness transformative changes in people's lives, right? This is a disease that is driven primarily by genetics and by trauma. And I think about my patients who started using opioids when they were 12 or 13 with their parents. And it's no wonder that that kid is going to have a hard time as an adult, right? They are much more likely to develop a use disorder themselves. And so I have the opportunity to work with these people later on, watch them get jobs, start families, go back to school. And that to me, is extremely rewarding. And then it's opportunities like this where I have the chance to come in and talk to communities who are interested in learning more and figuring out how they can help their neighbors. That makes me feel really hopeful. So thank you so much for having me here tonight. And let's kind of get on with it. I wanted to start just by providing a little bit of context in terms of where we are in terms of the opioid epidemic. So it's an interesting time because for the last 20 or so years, overdose deaths have just been steadily and at times very steeply climbing, to the point that 2 years ago, 110,000 people died in a single year from drug overdoses, right? Most of those, and that's all drug overdoses, but 3/4 of those involved an opioid. And spoiler alert, there's been data released pretty recently within the last 2 weeks that showed that overdose deaths are dropping for the first time. And we're going to talk about that. But I wanted to just kind of show you this really steady rise in overdose deaths over the last 20 years, really a 5-fold increase in deaths. But as of 2 weeks ago, the CDC released this new data that showed that overdose deaths dropped by 30%, almost 30%. And this is the lowest tally in the last 5 years since before the pandemic. And deaths declined in all major categories of drug use, so stimulants as well as opioids. And in every state except 2, Vermont was one of the states that it did drop. Nevada and South Dakota were the only 2 where they're still rising. And I think, everyone's wondering, what are we doing right? What has led to this decrease? And I think experts have kind of are agreeing that it has something to do with the changes in the illicit drug supply. So maybe the fentanyl is actually less potent right now, but also it's mostly greater access to treatment and greater access to Narcan. Those are the things that are keeping people alive. This doesn't mean that fewer people are struggling with addiction, right? It means that fewer people are dying, and we're giving people tools to at least help them stay alive until they're ready to get treatment. So you can see here the light blue bar is 100, and that was 2023. So you can see 110,000 people died in 2023. 2024, 80,000 people died. So that was a huge drop, right? But I'm a visual learner, and this is 80,000 people, right? It's still a football stadium full of people. People who are someone's kid, partner, family member, essentially dying a preventable death. So a little more context, drug overdoses have killed more Americans in the last 24 years than all US wars combined. Roughly 3 in 10 adults have been addicted to opioids who have a family member who has been, and less than half of those received any kind of treatment. It's the leading cause of death for Americans ages 18 to 44. That statistic always gets me. And then since 1999, more than 1 million people have died from drug overdoses. So our little state of Vermont has been hit really hard too. This is kind of an older chart that just goes up to 2022, but I include this because overdose deaths in Vermont actually increased by 70% during the pandemic, and that was the highest increase in the US. They measured that from April 2020 to April 2021, so you can see that big jump there. But we're seeing that little glimmer of hope in Vermont too. So the last 2 years, overdose deaths in Vermont have decreased ever so slightly. Again, that means we're keeping people alive. What we're starting to do is what we're doing is working. But there are certainly limitations to this data in the sense that people are still really struggling. This just gives you a better sense of, you can see 2022, the overdose deaths kind of hit their peak at, I think it was like 260, and we've had decreases the last 2 years. Okay, so we're primarily going to talk about opioids tonight, but I'm happy to answer specific questions at the end if you have questions about other drugs. But let's just start with what are opioids. So they're a class of natural, semi-synthetic, and synthetic drugs. And what they do is they bind to receptors that are on the nerve cells in the brain, spinal cord, gut, and other parts of the body. And when they attach to these receptors, they very effectively block pain signals between the brain and the body, which is why they're great for post-operative pain or part of anesthesia, right? They also affect areas of the brain that control emotions and pleasure. So not only do they actually block physical pain, but they can block emotional pain too. And there are kind of three categories. So there are natural opiates. These are made, derived directly from the opium poppy plant themselves. There are semi-synthetic opioids. These are created in a lab, but from natural components. And then the synthetic opioids that are entirely made in a lab, and they tend to be much more potent. And, like, as we know, fentanyl is 50 to 100 times stronger than morphine, typically. So what is addiction? This is the definition from the American Society of Addiction Medicine, which I like. So addiction's a treatable chronic medical disease involving complex interactions among the brain circuits, genetics, environment, and an individual's life experiences. People with addiction use substances or engage in behaviors that become compulsive and often continue despite harmful consequences. So the takeaways here, if you're going to remember three things that are potentially bolded and underlined. Addiction's treatable. It's a chronic medical disease, so that puts it in the same category as things like anxiety, depression, hypertension, diabetes, and it's complicated. So it involves your family history, your genetics, the environment, and the way you grew up. What is it not? So it's not a moral failing, it's not a choice, it's not a lack of willpower, and it's not a permanent state. So recovery is possible. So I want to, we're going to talk about risk factors for addiction. And I want to kind of open that conversation by telling you a story about a study called Rat Park, and I swear that this is relevant, and you might even find it interesting. So for many years, addiction was believed to be solely the consequence of a drug itself, right? That is, like, some drugs are just so inherently and irresistibly addictive that anyone who was exposed to them over a period of time would become addicted. And this was a theory that was based on studies that were done in rats. So these rats were put in these tiny little isolated cages by themselves, and they were given two options. They were given plain water, and then they were given water that had a drug in it, like typically it was morphine or cocaine. Unsurprisingly, and that was all they had in their cage, right? So unsurprisingly, these rats started compulsively consuming the morphine water. And that was what this is like what the understanding that addiction was just based solely on the characteristics of the drug came from this study, right? But then along comes this Canadian psychologist named Bruce Alexander, and he really challenged this theory. He said, well, maybe the compulsive consumption of that morphine water was due to the fact that the rats were living in these terrible, like bleak conditions, right? They were by themselves. There was nothing else around them. Of course they were going to use the drug water. Like what else were they going to do? So he decided to create what he called Rat Park, which he described as a spacious and socially vibrant environment for rats. So the cages were large. There were multiple rats of both sexes, which allowed for social behaviors, play, mating. There were stimulating objects like balls and wheels and other things to explore. There was comfortable nesting material, and nesting areas, which created this sense of security. And they also had the control group of the rats in the cages by themselves. And both of these groups were offered the plain water and the drug-laced water. And the results were really striking. The Rat Park rats consumed significantly less of the drug solution than the rats in the isolated cages. Even when the rats were forced to consume morphine for an extended period of time and were therefore dependent on morphine and put in Rat Park, they still chose the plain water over the morphine water. So the takeaway, right, was that a stimulating and socially rich environment can actually act as a protective factor against addiction. And distress and isolation are, in fact, major risk factors for addiction. And that this idea that drugs themselves are solely responsible for addiction is an oversimplification. And in his final report, he said, addiction isn't you, it's the cage that you live in. And I think, that always has stuck with me. And then there was another study that I think sort of further emphasizes this point, which was a study done of soldiers in the Vietnam War that showed that rates of heroin addiction were 20 times higher for soldiers stationed in Vietnam than for those at home in the US. But when those soldiers returned home, the rates of addiction fell to pre-deployment levels. So again, like addiction isn't you, it's the cage you live in. If you are in a war zone, you have a lot that you're coping with, right? So we'll talk about what we can do to help, but I think this gives us kind of early on a chance to reflect on what are our cages like in rural Vermont, right? And how can we create more vibrant ones and less isolated ones for our communities? So what we really know about the risk factors now, and a lot of this comes initially from Bruce Alexander's study. So there's individual risk factors. So genetics and family history are huge. So if your parents or your grandparents have a substance use disorder, you are about 8 times more likely than someone else to develop a substance use disorder. First use at a young age. So there's some research that shows up to 90% of people who have a substance use disorder started using substances before they were 18. Co-occurring mental health conditions, depression, anxiety, bipolar disorder, PTSD, OCD, history of trauma, and high ACE scores. Does anyone know what an ACE score is? We're going to talk about it, but so it stands for Adverse Childhood Experience. It's essentially I'll talk about it next. And then personality traits. So some traits like impulsivity, being sensation seeking, those can increase your risk. And then there's environmental risk factors. So the biggest one here is easy access to the drug. So when it's easier to access a drug, we're more likely to try it. And in trying it, we're more likely to get addicted to it. Peer influence, family environment, community and societal factors like poverty and stress. But I want to circle back to the ACE score. So ACE stands for Adverse Childhood Experiences, and this is a screening tool that was developed in the 90s, and it was also a big study was done at that time, and it essentially evaluates different kinds of abuse, neglect, and household challenges that someone may have experienced before they were 18. There's 10 categories, and you end up with a score ranging from 0 to 10. So it looks at abuse, neglect, did someone in your household have a mental illness? Did you have a parent incarcerated? Was there a family history of substance use? Were your parents separated? Did you witness domestic violence? And what was found is that folks with high ACE scores had higher, they were more likely to initiate substance use at an early age. There were higher rates of use disorders, recent IV drug use, lifetime overdose risk, higher rates of depression, anxiety, PTSD, suicide attempts, higher rates of stroke, cancer, diabetes, higher rates of involvement in the criminal justice system, homelessness, and even a reduced life expectancy. So, I think it can be easier to understand how addiction isn't a choice when you think about the risk factors and then you think about what a lot of folks who struggle with addiction have been through, right? And truly, a lot of this has to do with luck, right? Like one kid might be from a stable, supportive home, tries an opioid after school, that was fine, right? That kid's friend, who maybe unbeknownst to him, he has a high ACE score, right? His family life isn't as stable. He has a family history of substance use disorders. He tries that same opioid and maybe his life is never the same again. So again, these are folks who are essentially looking for a substance that's going to decrease physical and emotional pain, and that's what opioids do. So protective factors, kind of the opposite of what we just talked about. Low ACE scores, strong family bonds, parental involvement, supervised activities, organized activities for kids, and clear and consistent expectations from family, school, community, and then that decreased accessibility to substances. I'm just going to take a drink here. Okay. So we understand the risk factors. We understand the protective factors. Let's talk about what's going on in the brain of both, going on in a healthy brain and also in the brain of someone who's addicted to substances. And I think one of the reasons that it can be so difficult to understand addiction as a chronic disease is because, like other mental conditions, mental health conditions, there's not like a lab that we can do. There's not a CT that we can point to acutely and say, look, this person has addiction, right? It's not like checking someone's blood pressure and you can say, look, it's high, you have high blood pressure. We have to, similarly to depression or anxiety or bipolar disorder, we have to sort of visualize it ourselves in terms of like what's going on in the brain. So this is a representation of the limbic reward system. It's also known as the mesolimbic dopamine pathway. And we all have one of these. We all have one of these pathways in our brain. And what this reward system does is it teaches us what's good for us and encourages us to do that thing again. So it's designed essentially to reinforce behaviors that keep us alive, like eating, spending time with family and friends, reproducing. So what happens is we do something like, say, eat a really good meal, and our brain releases the neurotransmitter dopamine, which is this little chemical messenger that makes us feel pleasure and joy and satisfaction and really makes us want to do that thing again. So that's obviously really important for survival, right? We have a meal, we get dopamine, and we say, okay, we're going to do that again at some point. And as a result, we don't starve to death. For folks who use substances, they essentially have their reward system hijacked. So opioids and other substances trigger these huge amounts of dopamine to be really rapidly released. And so it's this huge and rapid release that creates this really powerful memory link in the brain so your brain goes, whoa, now that felt amazing. I'm definitely gonna do that again. Then what happens is with chronic exposure to the substance, the brain gets used to having all that extra dopamine. So our brains actually start producing less dopamine. And then they take it to the next level and they say, we're even going to get rid of some of our dopamine receptors. So there are fewer of those even available for dopamine to attach to. So what happens is without the use of a substance, a person's dopamine levels can drop to even kind of lower than normal levels. And the only way to get enough dopamine to start to feel better is the drug. And regular things like eating, spending time with family, right, no longer feel fun or satisfying because the brain is so desensitized to dopamine, and the amount of dopamine that they're getting from the meal or the time with friends and family is so little that it doesn't even really make a difference. So you're getting all of this dopamine. And And then further, chronic use leads to changes in other neurotransmitters like serotonin and GABA. And so these imbalances lead to mood changes, anxiety, increased impulsivity, which in turn makes it harder to resist cravings. Other changes start to take place in the brain. So the prefrontal cortex gets weaker. That's the part of the brain that's responsible for decision-making, control, impulse control, planning, reasoning. So it's the impact in the prefrontal cortex that makes it difficult for people to control their drug use, even when things are not going well, right? Even if they lose their housing or their children or their marriage dissolves. And then the amygdala and the stress systems also get more sensitive, so people tend to feel more quickly anxious and upset when they don't have access to the drug. So ultimately, people end up craving the drug just to feel normal. Other parts of their life become more difficult to enjoy, and they struggle to control impulses, which further exacerbate the drug use. So there are really real changes that are going on in the brain that make it virtually impossible for someone to just stop using the substance on their own. So how do we diagnose someone with an opioid use disorder? And this is actually, you could use these criteria to diagnose any kind of use disorder, whether it was a cocaine use disorder, it would be the same criteria. Again, we don't have a lab test or a vital sign that we can check. So we do a clinical interview with a patient, and we look at the criteria and we see if they meet these criteria. We think most often about the 3 C's of addiction, so cravings, lack of control, and continued use despite negative consequences. So let's talk about treatment options. Harm reduction, medication, behavioral interventions, and community and recovery supports. We're going to start by talking about medications. Like I mentioned earlier, and you're going to probably get sick of me basically retelling you this this right here, which is that people with opioid use disorder are up to 50% less likely to die when they're treated long-term with medications with buprenorphine or methadone. These are the 3 meds that are FDA approved to treat opioid use disorder. We're going to talk about each one of them quickly. I'm not going to get into the weeds on how exactly they work. Again, if you have questions after, happy to answer those. So methadone is a long-acting opioid agonist, prevents withdrawal symptoms for 24 hours. It can be started when someone's actively using unprescribed opioids, which is really important because someone does not have to go into withdrawal and feel sick to start this medicine. It's decreases the risk of overdose and all-cause death, improves social functioning and quality of life, decreases involvement in the criminal justice system. The challenges are that it's very highly regulated. So it has to be dispensed by an OTP, which is opioid treatment program, and it requires, at least initially, daily dosing. So folks have to get to the methadone clinic every day to get their medication. You can imagine how challenging that is in a rural area, right? And if you have a job, getting to the clinic before you start work, figuring out how you're going to get there, how you're going to have childcare during that time. So there are 9 clinics in Vermont. Not sure about New Hampshire, but the closest ones to here would be in West Leb or in Berlin. Yeah. Yeah, so it essentially means that, so methadone itself is an opioid. So agonist means that it fills the opioid receptors in the same way that an unprescribed opioid would, but it's long-acting and the goal is stabilization, not euphoria. So it's dosed to get to a point where someone can just function normally, if that makes sense. And I'm going to talk about I hear a lot the common misconception of like, well, aren't you just replacing one opioid for another? And I'm going to talk about that in a few slides here. Buprenorphine is a partial opioid agonist. So It's a little bit different, and this is kind of getting into the weeds a little bit, but it's different from methadone in the way that it sits in the receptor. So it's kind of like buprenorphine turns the light switch like halfway, like the dimmer's on, and methadone you're flipping the lights entirely on. Because it's a partial agonist, it's actually associated with less like respiratory depression, and it's essentially impossible to overdose on buprenorphine, whereas methadone, you could take enough to stop breathing. So buprenorphine can be prescribed as a film, tablet, or a weekly or monthly injection. The injectables are new and just a really great option for patients. Downside of buprenorphine, you have to be in some opioid withdrawal, so you have to be feeling kind of sick to start the medication, which can be really challenging for people. In our clinic, we try to give people non-opioid meds to help target some of those withdrawal symptoms so that they can successfully start the medication, and it can allow them to wait a little bit longer comfortably before we can safely start it. Similar to methadone, reduces all-cause mortality by more than 50%, decreases unprescribed opioid use, reduces participation in illegal activities, does not require daily dosing, and is less regulated than methadone, so you can send someone a 30-day supply the first time you meet them if you want. And any provider, NP, doc, PA who has a DEA license can prescribe this. So it just means that you can prescribe controlled substances. So like opioids or benzodiazepines would be another one. Yeah, thank you. Yeah. So common misconception, I hear this a lot, and a lot of my patients even feel this way. Like sometimes they're just replacing one opioid with another. And the answer is technically yes, right? If we went back to that original chart, we would see fentanyl, methadone, buprenorphine, heroin, morphine on the same chart. These are all opioids. However, buprenorphine and methadone are FDA approved. They're regulated. We can give someone an actual dose of the medication and know what they're getting. They're long acting. You're 50% less likely to die when you're on one of these opioids. Their use leads to decreased unprescribed opioid use, fewer opioid-related deaths, decreased criminal activity, decreased transmission of infectious diseases. So no unprescribed opioid that you're getting on the street is associated with any of that. So, you can get into the semantics of, yes, technically they're opioids, but they're used entirely differently, and they have very different outcomes. If you are, though, looking for a medication that is not an opioid, naltrexone is an opioid antagonist. It's FDA approved for opioid use disorder. It's a blocker. So essentially what happens is if you are on naltrexone and you take an opioid, it just doesn't work. It's given as a monthly injection. Big challenge here is someone has to be opioid free for over a week before we can start it safely. So I typically see this, folks maybe start this while they're inpatient somewhere, they come home, and then we're able to continue it. But it's really hard kind of in the normal world to be sober for 7 to 10 days. It also is associated with higher risks of return to use and overdose than methadone and buprenorphine. The biggest thing is because it's not an opioid, if you're using this and say you skip a dose and then you go and you use the amount of fentanyl you were using before, you're going to have no tolerance and you're going to be much more likely to overdose. So I just wanted to circle back to this that we talked about earlier. So I just think, when you think about how effective the medications are, to think that less than half of the people are getting any kind of treatment, and really the number of people who are getting any kind of treatment with medication is even less than this. It's more like 25%. And medication is the gold standard, best treatment for opioid use disorder. Okay, so what else do we do other than meds? We certainly try to get people involved in counseling, mutual support groups like NA, Smart Recovery, sponsors, working with peer recovery coaches. And we try to get people to the right level of care. So some folks, like being an outpatient right away isn't really going to meet the level of care that they need. So some people need to start in like a residential treatment setting, which would be where you're living in a treatment program for usually 2 to 4 weeks. There's also intensive outpatient programs. It's usually 3 hours of structured like time a few days a week for 6 weeks or so. And then there's outpatient treatment, which is like what we do in the clinic setting. Very often people will start inpatient, then come out of the residential level, maybe do an intensive outpatient program and also see us. And then I think you guys are having a separate series event just about harm reduction, which is great. So I'll just touch on this briefly, but so harm reduction is an evidence-based approach that's aimed at reducing the negative consequences and the risks associated with ongoing substance use. So it essentially accepts that for better or worse, drug use is part of our world, and it chooses to work to minimize its harmful effects rather than simply ignoring the problem or condemning it. And a lot of you are probably already doing some of these things, but some examples of harm reduction would be Narcan distribution, overdose education, fentanyl and xylazine test strips, safe injection practices. This is not teaching someone how to get more out of their drug. This is teaching someone how to safely inject in a way that is going to prevent them from getting a huge abscess on their arm, a bloodstream infection, and needing open heart surgery, right? Wound care, syringe and needle exchange programs. Again, this is less about giving people the supplies to do their drug and more about reducing the harms and making sure that, one, syringes and needles aren't lying around your community, and two, that rates of infectious disease are not going up. Infectious disease testing and treatment, and then routine immunizations would be another example. So what about the role of law enforcement? I'm going to like teeny tiny dip my toe in here because this is not my wheelhouse at all. And it's always a hotly debated topic. And I think you'll also be hearing from someone in law enforcement, maybe kind of a lawyer. Okay. So, all right. So I can give you my perspective as a medical provider again. And what I would say is what I've been saying, which is that there's clear evidence that treatment with bup or methadone decreases involvement in illegal activity, reduces the need for illicit drug use, decreases drug-seeking behavior, reduces drug-related crime, improves social functioning, and it's cost-effective. So economic modeling shows that the cost of treating someone with a medication is far cheaper generally than dealing with the consequences of ongoing criminal activity. So if your goal is to reduce crime in your community, my recommendation would be try to get people into treatment. So how can you help? To preface this, if there was a silver bullet, we'd all be doing it, right? Towns, communities, states across the country are trying to figure out what the best way to help is. And I don't think there's any one thing that we can do, but I think there are a lot of things that have the potential to have a positive impact on our communities and our state. So prevention, understanding the treatment options, knowing your local resources, creating safe spaces, reducing stigma, being kind, practicing harm reduction, and taking care of yourself. And a lot of this stuff you all already know, having had some of these conversations before and seeing some of your notes from those conversations, I don't think any of this, unfortunately, maybe is brand new to you. But when I think about prevention, right, how can we prevent addiction in our community? How can we prevent and how can we protect our young people? Early education and awareness. So implementing evidence-based prevention programs in schools and community settings, educating kids about the risks of substance use, building resilience, teaching healthy coping skills. parental and caregiver education, providing resources for parents and caregivers about how to talk to their kids about drugs and alcohol, how to recognize warning signs, how to create supportive home environments, promoting protective factors, focus on preventing or delaying that initial use before, the brain is fully developed. Nitty gritty is like safe storage and disposal. If you have opioids at home, getting rid of them appropriately and being able to recognize the signs and symptoms of early use. So that would be things like new problems at school or work, money problems, changes in behavior, mood, neglected appearance. And then supporting both local and federal prevention efforts. So supporting local organizations, advocating for mental health resources and housing, advocating for continued funding for substance use treatment. There's a lot of talk right now at the federal level of cutting Medicaid, which would decrease access to substance use treatment for millions of Americans. Medicaid's the single biggest payer for drug treatment in the country. And I can tell you that most of our patients, when they start at the clinic, either have no insurance or they have Medicaid. Very often, once they get stable on meds, they get a job and end up on private insurance through their employers, which actually impacts our funding at our clinic, which is interesting. So they just count Medicaid people, and we're like, you guys need, like, this is a good sign if we have fewer Medicaid people and more people with private insurance, right? So we're working on that. And I think this is a really big one. So understanding and promoting meds for opioid use disorder as life-saving care. So understanding the facts, challenging misconceptions, understanding the options that people have, encouraging folks to seek treatment, and again, like supporting that legislation that increases access for folks. Knowing your local resources. I put some of these handouts up front, and this is a little outdated and I need to update some things, but one of the most important things we can do is know what we can do to help, right? So time is of the essence. If you have an interaction with someone and they mention, I really want to stop or I really want to get help. If you immediately know what you can do to help that person get treatment and where that treatment is, you're so much more likely to be able to help that person than if you have that same conversation of, oh, I need to get help, and you have no idea where to start, right? Because fentanyl does not last very long in the system. And so if someone says they want help, but they start to feel sick, right, it might be too late. So it's really about quickly getting people to care. So I'll just tell you quickly about our clinic. I think we look like a really friendly and approachable group. So we're based in Randolph and Berlin. We offer low barrier care. So the takeaway here is I don't need a referral from anyone. I don't need every medical record that you've ever had or proof of anything. You can just call or you can just show up and I will make sure that you're seen. Our goal is to make it as easy as possible. Like I said, if you have someone, they want to get care, I'll see them, right? We do not offer methadone because we are not a methadone clinic, but we prescribe mostly buprenorphine and the Vivitrol and naltrexone. We're also a Narcan distribution site. We have test strips. We accept all medication or all insurance. I'm the only provider. We have a nurse. We also have a counselor. And then Janet, who works at the front desk, who keeps us all alive and afloat. So that's kind of part of knowing your local resources. And then creating safe spaces. So I was talking to a patient about this last week, and I asked her what she would say to someone about like how to encourage people to get into treatment. Because I think that's always the question, right? Like we have these treatments, they work really well, but how do we get people into treatment? And her response was create more safe spaces, which I really like because it feels to me really tangible, right? Like if we zoom out, maybe that means safe spaces for kids, like after school programs or recovery groups for adults. But if we zoom in, like each one of us can be that safe space for someone. like if we all tonight here decide that we're going to be a safe space, the likelihood that we can get people into treatment is so much greater. So understanding this as a chronic disease, offering empathy, kindness, understanding, developing relationships over time, gently encouraging people to get treatment. And you really never know which interaction is going to be the one, right? Like even with quitting smoking, there's data that shows the more times your PCP brings it up, the more likely you are to quit. And it doesn't have to be like, these are all the things. It can just be like, have you thought about quitting smoking lately, right? It's little opportunities over time. And that kind of segues us into talking about stigma, what it is, why does it matter, and what can we do to fight against stigma. Essentially, it's a set of negative attitudes, beliefs, and discriminatory behaviors that are directed at folks who use substances, right? And what it does is it prevents people from accessing care, prevents people from coming forward, especially early in their addiction, asking for help, encourages people to deny their illness, increases the risk of overdose, prevents pregnant women regularly from seeking treatment, and makes people feel like they're incapable of treatment. This is a disease that is rooted in shame. Every patient I have can tell you a story about a time that they asked for help and they were treated without respect and not even offered the treatment, the gold standard treatment options that exist. So it's our opportunity to be the people who stick up when folks are having a hard time. That can be something as simple as like using the right language, right? Staying away from discriminatory terms like addict, junkie, user. Maybe you have heard of person first language, but person with a substance use disorder, person who uses drugs, getting away from terminology like medication assisted treatment, which we don't use for any other medical conditions. We don't say if you're on Prozac that you're on medication assisted treatment. You're just on medication for depression, right? Or anxiety. What else can you do? You can practice harm reduction, right? You can carry Narcan, know CPR, can learn to recognize an opioid overdose, know how to give Narcan. And then you need to make sure to take care of yourself too, right? There's a lot of really good resources for folks out there, friends, family members of folks who are struggling with addiction. This is a great one from the Grayken Center at Boston Medical Center. They have groups online twice a month, and there's a lot of other ones too. So addiction's treatable. It's a chronic medical disease. There are safe, there are life-saving meds available. Long-term use of methadone and buprenorphine decrease involvement in illegal activity. They decrease the likelihood that you're going to die. You can make a difference by knowing the facts, understanding the treatment options, combating stigma, and being a safe space, and recovery is possible. So I'll take whatever questions you guys have, and I'll put my contact up here. I do just want to plug that you can call our clinic at any time if you have a question, a concern, you're trying to help someone, whatever, we're happy. If you give us a call, you'll get on the phone with either my nurse or me, and we will do everything we can to help.
Come to the ER.
If a patient goes to the ER, so for opioid use disorder, so they should be offered treatment. It depends what they're looking for, right? But you can certainly, the emergency room is a space that you can go to and you can say, I'm in withdrawal from opioids and I would like to start buprenorphine. Methadone is trickier to start in the emergency room. But that is a very common way that people access treatment. It's also can be a really traumatizing way for people to access treatment. So again, if you have someone who's looking for buprenorphine, which is, you've probably heard of Suboxone, which is buprenorphine and one other medication, but if you have someone who's looking for Suboxone or one of the long-acting injectables, have them call our clinic or show up. I mean, it has to be during the week is the downside, right? Yep. ER night and weekends. If folks go to the Gifford emergency room, they are getting much better at getting folks in treatment and then getting them to follow up with us the next day that we're back in clinic. They should be able to safely get them started and give them enough of the medication until their appointment with us. Yeah, so in Randolph, we're at the Kingwood Clinic, which is where physical therapy is. Yeah, if you come off the exit, you go down the hill past McDonald's, we're like before you get to the bottom of the hill. Yep. Yeah, so they can walk in during our normal hours. If it's a walk-in, if it's truly a walk-in and I don't know that they're coming, they may have to wait because I'm going to see my scheduled people. But I will absolutely make sure that they are seen that day. Between 5 and 14. Yeah, so I would say we have a relationship when, yeah, so like some of our folks I'll send to Clara Martin to do the intensive outpatient programs, or we get referrals from Clara Martin. Most of the like statewide resource, we're in the databases for most of the statewide resources like HelpLink and stuff like that. Not like one that we're using regularly, but they are aware of us. Yeah. 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 Any other questions? It's a lot of info. Yeah.
This behavior of people who are addicted strikes me as what I understand to be wholesome behavior.
Mm-hmm.
Doing something no you shouldn't, but perhaps decided not to do it. And yet do it, anyone who's ever had trouble keeping their weight down. That's it.
Mm-hmm.
Common sense.
Mm-hmm.
So, compulsive behavior. Is there anything we can do to stop people from the first time use? At which point it is not compulsive. It actually is a choice.
Right. That first, yeah.
That first time. How do we head that?
Great question.
I just got a message from someone on the Zoom that they can't hear the questions.
Oh, okay. Sure. Yeah. So the question was, how can we prevent the initial use of a substance or opioids? And that's a really good question. I think some of the things we talked about earlier, in terms of like, how can you limit access to the drug initially, within your community, not having even prescription opioids lying around, right? Like you had that back surgery 2 months ago and you've got your 5 oxycodone left. Getting rid of that, disposing of that correctly so that, your kid or a friend isn't going to find it and use it for the first time. Keeping, especially young people busy and engaged with like we talked about organized activities, right? And then the other thing that I think is really important is having conversations with young people about understanding their individual risk, right? Like if you have a family history of addiction, getting young people to understand that that puts them at a much, much higher risk of developing an addiction themselves, even if they only use it a couple times, right? The likelihood is so much higher. Those would kind of be the main things, yeah. Yeah. childhood traumas. Hmm. Yeah. And access to mental health care, right? Like access to counseling at school if this stuff is going on at home, having resources for kids to kind of have help in navigating that.
Here often when young people get involved with drugs, opioids and others, at that young age, it interrupts their development. And can you talk about that to a degree, or how, those would be, I think, I don't want to use your tactics with kids, but it seems like it's a legitimate thing for people to be more aware of is to how it interrupts development and what is that that's getting interrupted and doesn't get recovered, or, what's the degree of impact?
Yeah, so that's a good question. And that's really going to depend on like the frequency and the, oh, sorry. So, how does substance use at a young age impact development? Does that summarize it well? Okay. So it's really going to depend on the amount and the frequency of the drug use, right? I think as we kind of talked about, the likelihood of becoming addicted to a substance is higher if you start using it when you're younger. So for a lot of my patients started using opioids when they were 12 at home with their parents, truly. And so it impacts the brain in all those ways we talked about, right? It changes that balance of dopamine. It starts to change the other neurotransmitters like GABA and serotonin. But generally, that's going to be, a young person's brain is, can adapt pretty quickly. So generally, if the use can be contained, then that brain can return to normal. Now, there's always a tipping point, right? Like we see this in alcohol use disorder a lot. At a certain point, there's chronic brain damage that occurs that cannot be recovered. But when that point is really hard to tell because there are just so many variables.
Taking a customized version of this to the schools with students, for young people to see what happens to them.
Yeah, so the question was that the pathophysiology was helpful, and have we thought about talking about this in schools? I particularly have not, well, I guess it has crossed my mind, but that is one of the things, right? Is like, how do we get evidence-based information into schools? Yeah, I mean, I'd be happy to do it in some capacity, but there's probably someone even better out there and better equipped to work with kids on this. But yeah, I think, for so long, the strategy was just telling kids that drugs are bad and they shouldn't do them. And as any parent of a toddler or a teenager knows, if you tell them not to do something, they're going to want to do that thing. So adapting, right, and figuring out like what's the right amount of information to give to kids so that they actually understand why we're saying don't do drugs.
And kind of this feeling like these folks don't want to get help. And so that's part of the movement towards the criminal legal system. Do you have suggestions for how, I know you already said like consistently telling people what help is available is useful, but any other suggestions for how to approach someone or navigate someone who might not be in a place yet? What you can expect, like how long is it?
Yeah, so the question is how to help people who are in active addiction and not seeming ready for treatment. Is that right? Okay. Yeah, this is like the age-old eternal question. And I ask this, I've had a lot of conversations with my patients about this because they're the experts, right? And there's no great answer, right? There's no like perfect solution here. And most of my patients would say that something's going to happen that's going to be too much for the person and they're going to be ready for treatment. And all you can do in the meantime is make sure that people understand the resources, try to help keep people safe, and the more you can kind of, and this is not easy. Like this is very hard to try to create a positive relationship with someone who's doing things in your community that make you very unhappy, right? Like this is just to get that out there. Like this is very hard. And you kind of have to have this understanding, this view of the world that is like people are good, right? And this is someone with a healthy brain would not be doing these things. But the more that you're able to just cultivate a trusting relationship with people, the more likely it is that they're going to want to get care. But I wish I had like that answer because that would solve a lot of the challenges that we face. And I struggle with that most days in the clinic when I'm like, I don't have a full schedule and I know there are a lot of people out there who need help. And it's like, how can we get to those people and get them in here? And that's our biggest challenge. And like I mentioned with overdose deaths in Vermont dropping, like the limited data that we have shows that, the number of people in active addiction is still as high or higher than it was when overdose deaths were higher. And across the board, fewer people are accessing treatment. So that's something that kind of like statewide, other addiction professionals we're trying to figure that out. Fentanyl has been challenging in the sense that a lot of people do not want to start buprenorphine products well on fentanyl because you have to get into moderate withdrawal before you can start it. And in the days of heroin, that meant maybe waiting like 12 hours since you last used heroin. In the age of fentanyl, that means waiting more like 48, 72 hours sometimes, which is a really long time to feel sick. So I think that's partly contributing to why people are hesitant to come in and get treatment, because they're just hearing that it's harder to start. And it is more complicated to start now. Yeah.
Get methadone less controlled.
Yes. Sorry, did I cut you off? The question is, what about making methadone less regulated and easier to access? And that has been a goal of people working in addiction for a really long time. There are a lot of reasons why it's highly regulated. A lot of them are political and were political at the time that these regulations were put in place. I'm fairly confident that in the near future, in the next number of years, it will be more accessible and easier to prescribe in outpatient, just normal addiction clinics. And I think the challenge of how to get people into treatment would still exist, but I do think we'd see an increase volume if there was that other option. So people tend to describe it as, thank you, sorry. What does it feel like when people are in withdrawal? So most people would describe it as like the worst flu of your life. Generally, it starts, well, everyone's early withdrawal symptoms are different, but general withdrawal symptoms would be nausea, vomiting, headache, runny nose, excessive yawning, sweating, chills, just feeling really crummy, body aches. Yep.
But hear a lot about meth and crack
Mhm.
and cocaine.
Mhm.
Do those things have similar, what was the word? Oh, agonists. Are there similar treatments in them? Or they have maybe a different?
Yeah, good question. So, question is hearing more about stimulants like crack, cocaine, methamphetamines, and are there treatment options? So, yes, we're seeing a lot more stimulant use, very often in combination with opioids. Unfortunately, there are not great treatment options for stimulant use disorders. So there are no meds that are approved by the FDA. There are a handful that can be used off-label that there's limited and mixed evidence that they really do much when compared to giving someone the placebo or a sugar pill. I haven't used them often. What I find regularly is that to get to the dose that is required, people end up with a ton of side effects and they decide they don't want to do it, right? What is evidence-based as the first line treatment for a stimulant use disorder is something called contingency management, which is not a medication, but it's a program essentially where folks are brought into the clinic and usually a urine drug screen is done and essentially people are rewarded for having a negative urine drug screen. So if there's no stimulant in their system, maybe they're given a gift card or the opportunity to like draw out of a hat and maybe get some kind of reward. And with the goal being rewiring the brain around dopamine, right? To teach the brain that you can get rewards and you can get dopamine from things other than the drug. There's a lot of data that shows that it works really well. The problem is, and this is like a pipe dream of mine, would be to get a contingency management program going at Gifford, but there just aren't many of them. And there are really tight regulations around the amount of money that can be used for these programs, like for the reward part. And like the studies show that you need more money than we're allowed to actually use. So, but that is extremely effective when it's set up correctly. I would love to do that. There's been less of a focus because typically, the risk of death and overdose from opioids is much higher because of the impact that it has on the way we breathe. So it essentially you take too much of an opioid and you can stop breathing. Stimulant use tends to lead to more chronic problems over time and ultimately increases your risk of having a stroke or a heart attack or something like that. But you don't see the acute overdose deaths the same way that you do with opioids.
Is total recovery possible? Describe the drugs messing up your metabolism. Is it possible to get your metabolism back to the way it was before you ever took drugs?
Good question. So is it possible to, is total recovery ever possible? So the definition of a chronic disease, right, is that it's never going to completely go away. But I would say that people are able to safely navigate addiction and remain abstinent for many, many, many years. It depends on the person, I would say, in terms of how many times it might take to go through treatment, get sober, and stay sober, because return to use or relapse is certainly extremely common. And I think the average is like it takes people 6 or 7 times of trying to get treatment before they're able to maintain it. But this is something that most people would say they're navigating every day, right? Every day they're waking up and they're deciding, I'm not going to use an opioid today. And I think people would tell you it gets easier with time, but it's never something that's just completely going to go away.
Recommend, what are some things we can do at Bethel at our businesses, our places of worship, our schools, that would be in line with a prevention model here?
Yeah, so I think, what are things that can be done within the community to support prevention efforts, or what are the prevention efforts? I think obviously in schools, the big things would be having access to mental health care and counseling, like we talked about, having evidence-based programming in schools so that kids really understand what addiction is, what the risk factors are, and then getting kids, like programming for kids after school that's supervised, supportive. The more role models that young people have that they can look to, the more trusted folks that people have, if things aren't going well, to come forward to, right? Like we talked about stigma, people not wanting to come forward early on, especially. If you're a young person who maybe is dabbling with substances or struggling with them, if there are adults in their life that they can come to and ask for help and explain what's going on, they're much more likely to get help, right? So that's a really big one. And then, in other settings in the community, I think, again, just making people aware of resources is so huge. If people, I took over the clinic at Gifford almost 2 years ago, and it had been in existence since 2017. And I meet people every day who don't know that we exist. Like people in Randolph are like, oh, I didn't know that we had addiction treatment. And I have people call me and wanting treatment, and they're like, well, there's probably a long wait list and blah, 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 because there was for many years. But just getting the information out there, there's not a wait list. There are easy treatment options. The more you can kind of publicize that, I think that's kind of like the low-hanging fruit. And then I think continuing to support people as much as you feel able to in terms of, food shelf, other local resources, trying to help people, access housing or food, or like the basic essentials makes a big difference too. It's a lot of things. Yeah.
That's what the resources are. In the gas station bathroom, like anywhere that people go is the best place to start, because then you don't have to think about outreach. It's like people are already here, so let's give them the information here.
And I have people all the time that call and are looking for treatment, and they were like, I saw your flyer. And it feels so old school to me, hanging up flyers. But it's the flyers that people see that, again, if you think about stigma, it's especially the flyers that people see in private areas like bathrooms or anywhere, but they're more likely to take a picture of it or like rip off one of the tags if it's in a private area. In like a crisis situation.
But maybe half of people are ready to confront them and maybe bring in support or education like yourself to be a part of it.
So the question is, am I involved in interventions with folks who are maybe not quite ready for treatment, but there are people who are around them encouraging them to get treatment? So no, I'm not involved in that. Is the short answer, I guess. I think, I'm happy to provide information to people, but I think in my role, I'm not sure that that would be, that's something I would do. Sometimes though, like I encourage people, like people can come in for an appointment with me and they're not agreeing to anything, right? Like they can just come in, and we can have a conversation. Usually the way I phrase things is like, I want to figure out what's going on with you. I want to share some information about, the treatment options. And if there's anything that sounds appealing to you or anything that you feel like you'd be interested in trying, then let's do it. But it's very much shared decision making, right? And people can come in, learn all the stuff and leave and not want to do anything. And often those people come back and they're like, okay, now I know who you are. I know where the clinic is. It wasn't super scary. You were nice, right? Like I understand the options. So sometimes framing it as like, you can just go in and learn information. You don't have to agree to anything. Sometimes I see spouses convincing people to come in, right? Just to, or friends will, people have to consent to be seen. Like I'm not going to, people have to agree to be there. But certainly, sometimes friends or family members encourage folks to come in, and that sometimes works. Anything else? Yeah, please don't hesitate to reach out.
Thank you, Rob.